phone on mute. If there's too much background noise, because you can't help it or where you're at, I'll just mute everybody and then you can use the chat window to get unmuted. So welcome everybody to the March call of the monthly newborn screening pilots. My name is Amy Brower and I work for ACMG on the NBSTRN project. We'd like to welcome anybody who's new to the monthly call and give you a chance to introduce yourself or your team if you would like to.
Hi, this is Cindy Hinton. I'm with the CDC Newborn Screening Program, and I'm new to this call.
Yay, welcome back, Dr. Hinton.
Thank you, Dr. Brower.
That's exciting. Anybody else? Okay, great. We'll move into our standing agenda. We start out with an update from pilot teams with active or completed pilots, and then hear from other states that are screening for any of the new conditions that have been recently added to the RUSP or any other conditions that they might be working on. Then we'll have a little bit of discussion time, followed by an update from New Steps, NBSTRN, and then talk about upcoming calls. So we always start with New York, and what we're trying to do, we are, as you know, NBSTRN is sort of building a new website and a new approach to keep track of what you all report every month, including the functionality to let you report yourself ahead of time. So what I'm going to do today is try to keep on the left side, or at least in the red text, what you told us in February and what you all discussed in February, and then take notes during the call for the March report. So with that, I'll call on the New York team and see if you guys want to give us any updates on what you've been up to.
Hello, Amy, it's Joe. I'm providing the update today. Hello, everybody. So it looks like for NPS 1, let me see, is the text on the left, that's from our New York update last time, correct?
That's right. Yep.
Okay. I just don't want to repeat some of the information that's there. So starting with NPS 1, I will give the big broader number. We're up to 110,000 screens, and still to date, there's no classic cases. And there's a couple that we have one or two cases that we're a little suspicious of that may be attenuated MPS 1, and but we're kind of doubting it at this point. But we need to wait until we get a little more follow up on those. But we've had 9 referrals for MPS 1 since we started, and we've screened about 111,000 babies.
So that's kind of what we're going to be looking all the time for this.
So that's MPS 1. That's the MPS no real update. We're still with the 4 cases described on this page.
Hey, Joe, just a second. I'm going to mute everybody and then unmute you because there's some background.
Nearly everything is left in solution, a little bit.
There you go, Joe. So now you can continue.
Can you hear me, Amy?
Yep, I can hear you.
Okay. Yeah, so that covers MPS 1 and SMA. For Pompeii, I can give more of the total numbers. It looks like last time we talked about new cases, but what we have, hang on a second, we got to switch screens for a second. So we've now screened about just under 1.1 million babies. We have 8 classic infantile cases, a non-classic infantile case, and then approximately 45 or so possible Pompeii cases for late onset that would be. We've heard recently of some other non-classic infantile cases, and we're trying to get a better handle, but our non-classic number might be somewhere in the 2 to 3 range now, 3 range, I should say. So we're trying to get a better feel for that. We don't have good feedback at this point. We're trying to get it.
Okay.
And then for ALD, we're at about 1.3 million screens, and 37 boys is with ALD. That would be mutation and elevated marker. Some of these we're really looking at closely with other states in a project we've got going on to evaluate our cutoffs, but throughout the country, that is kind of a harmonization of cutoff approach. We're going to be having that meeting in a couple weeks. And then we have 33 females with mutations and elevated marker. The reason it's a little bit iffy is when you get into the what's the elevated marker and some of the issues we're having across diagnostic labs and trying to understand this better. But that's where we stand. It's about a 1 in 18,000 incidence rate, kind of in line with what's expected, but less than some states are seeing. So that's one of the reasons it's prompting us to look closer at our cutoffs relative to everybody else's cutoffs. That's it for New York.
Great. Let me unmute everybody and see if they have any questions for you, Joe.
I would say that we're comparing the exact amount of protein from
everybody,
and that orientation is actually affecting the output. And we can do it at different concentrations of protein on the surface to assess does the concentration.
It feels like somebody is presenting. I'm going to mute everybody.
That's kind of where we're at.
Okay, Joe, thanks for your report. I think the thing might be because of the video. Let me see if I can stop the recording.
Okay.
I don't know. It sounds like, because it sounds like it's your voice. Let me try it again.
Kind of where we're at. And we believe that we've now got what we call predictive loading. Meaning, if you put this much of protein in solution,
oh, yeah, it's not you, Joe.
If there's no
I don't remember saying protein.
Is compromising.
Okay, somebody is giving a talk while they're dialed into this call. So unfortunately, I'm going to have to leave everybody muted during the state reports, and then we'll see if they're done with their call and we can take any questions. Feel free to type in any questions in the chat box if it's helpful. I can't really tell who is having all the background issues. With that, I'll see if there's anybody on the line from the Wisconsin team that wants to give us an update. If you're not logged in with your name, you'll have to message me on the chat box and tell me what your phone number is so I can unmute you.
Amy, this is Marcy Sontag. I think we can all probably unmute ourselves. So if somebody has questions for Joe, they could probably unmute themselves and ask.
Oh, that's a good idea. So if you'd like to ask Joe a question, let me go back to New York. Feel free to unmute yourself. Thanks, Dr. Sontag, for that reminder. I'm still a little bit new to Zoom. So let's see if there's any questions for Joe. We'll give you guys a minute or so to jump in.
Hi, it's Annette Weigenbaum here. Can you hear me?
Yes, thank you. Go ahead.
Hi, since nobody has a question, I have one. How did you determine that the NPS 1 cases were attenuated, per se?
Have any attenuated cases yet, but we are trying to make that determination that the GAGs in the urine were slightly elevated and enzyme is low but not real low. So it's on the fence. We actually are waiting for physicians to do a repeat set of testing on the urine GAGs to see if they normalize.
Oh, okay.
And I think, Joe, that, you know, and Dr. Sontag and Joe, you guys can correct me if I'm wrong, but I think that we had put out your follow-up algorithm for MPS 1, or sort of like what you guys go through for GAGs in urine and the enzymes and what you look at. And I think that got built into some of the case definitions. So if anybody has any questions about New York's algorithm or what the case definitions look like, let us know.
We also have molecular analysis data from our second tier screening. So there was a severe, the most common severe mutation, or MPS 1 causing mutation, is on one allele, and then there was a boost on the other allele. So that's why we're we don't know what the, you know, we're trying to figure out this boost that's causing us problems, but it looks like it's probably going to be fine. This baby will probably be fine. Just being an extra caution.
Great. Any other questions for Dr. Rossini? Okay, we'll move on to Wisconsin. So if there's anybody from Wisconsin on the line, feel free to unmute yourself and we can have an update. Okay, let's move on to Massachusetts.
If anyone needs to talk and you're on the phone, I think it's *7 to unmute. There might be people who are just called in.
Georgia?
Can you hear me, Amy?
Yeah, we sure can.
Oh, great. This is Angela. I'm here. I don't know if anybody else is here. You know, MPS ALD, Pompe, that's been done for a while. We have started our SMA pilot, and so far so good. It's just a couple weeks now. We are doing the jointly screening on with our SCID screening on the PCR machine. Don't ask me any more technical things than that. We have actually had 2 positives so far. Our first one, it didn't show 0 presence of the SMN1 gene, but it was reduced. So we did follow up on that kid and we got diagnostic testing, and that child was normal. So, so there's that. We had one other screen that showed 0 presence of the SMN1 gene, and when I called out on that child, they already knew. So that it was kind of a weird situation. This screen was collected at 1 month of age, and the previous screens on the child were collected before we had started our pilot, so we didn't even screen the initial specimens for SMA. But here at 1 month of age, we screened it, picked the kid up, and they had already diagnosed the child as having SMA type 0. So that child's under care from that local hospital. And but it was good to know that our screen is working, and we had immediate confirmation that it was picking up the right thing for that child. So that's where we're at with SMA, and that's kind of about it.
So Angela, when did you guys start the pilot?
A couple weeks ago. Actually, it's been a month. February 4th or 5th. Right. One of those days, right in there.
Any estimate on the total number, or?
That's a great question.
Just curious.
So we screen here. Actually, I can do some quick, really rough math for you. 1, 2, 3 divided by 12. Our birth rate's usually around 130,000 a year, so we've probably done 10 to 11,000 samples so far.
Okay.
That's rough Angela math.
And Angela, you guys are combining it with the SCID assay. And then what you're reporting out is the SMN1 redo?
Exactly.
Okay.
And we keep it pretty simple when we actually report it to folks. We just tell them it's abnormal and they have to do what we say. But we did get, we do have funding in this NIH pilot to do the diagnostic testing. So all the testing is coming to the EGL lab here in Atlanta, which is nice. They're kind of expediting that for us and getting that right directly to us. So it's going well so far.
Great. So is the pilot scheduled to do 80,000 kids or 18 months, or do you have any timeline?
We are doing 15 months.
Okay.
I think.
Great. Thank you. Any questions for Angela? *6 to unmute yourself, or just click the microphone if you're on your computer. Great.
And I apologize. We can firm up some of these numbers at our next meeting in terms of how many we're screening and you know, the exact start date and things like that. Our whole program's been a little all over the place here.
Yeah. No, that's
so here we are.
Yeah. Thank you. How about North Carolina?
Hi, this is Jennifer. Can you guys hear me?
Yeah, hi, Dr. Taylor.
Hi, how are you?
I'm good, thanks.
Good. So we are still screening for SMA under the Early Check program. We're now a little over 1,700 specimens screened and no screen positives so far.
Do you want to talk a little bit about your methodology, Jennifer?
Sure. So we are doing a PCR method, just looking at the SMN1. We are not combining it with the SCID screening since this is under a consented model. So the two are separated. But we're just looking and see if SMN1 is present, the exon 7 is present or absent. We're using the method that the CDC developed.
Great. And Jennifer, is your pilot a certain length of time or a certain number of screens?
So we'll try to get as many as we can screen until March 2020.
Great. I know Georgia and North Carolina and other folks that are doing SMA, that I think the advisory committee had on their sort of plans to get an update on SMA screening and outcomes. Are any of you guys part of the planning for that? Or it might be a little early for I can't remember if it was a year or 2 years after the vote for SMA.
I am not participating. I'm not involved in that.
Okay. We'll keep a handle on that and talk to the folks at the advisory committee and just see if there's anything that would be helpful for any of you guys to do for that update. Yeah, thank you. Any questions for Dr. Taylor? *6 to unmute or click the microphone. Okay, very straightforward. So now I'll turn it over to updates from other states. I don't know if Virginia is on the line and you guys want to give an update. We certainly don't need to go in this order, but if Virginia's on and they have anything they'd like to talk about, feel free. Okay, let's see. Any updates from any other states or any other groups or anything you guys would like to talk about related to these new conditions?
Hi, this is Julie from Nebraska.
Hi, Julie.
Hi. I just have a very brief update, and then Crystal will be able to provide you our numbers for Pompe, MPS1, and XALD. But I just wanted to mention that in January, our advisory committee did recommend that we add SMA to our mandatory screening panel. And so unlike our usual process where we wait for our administration's agreement or disagreement with that, we have gone ahead and submitted the request to just add that via our regulations. There has been an administrative request that all of the regulations that went through this previous review in 2017 to try to reduce regulatory language, that all of those finally go through, and their request is that they all go through by this summer. So we tacked it into that version, and we'll see if it ultimately gets approval to go to public hearing, and then would likely be added after that.
Oh, that's
the request from the advisory committee was that they'd really like to see it implemented by July, and our laboratory probably would be fine doing that because I think they've already started, but they don't have a multiplex assay just yet. It's a separate assay. So we'll see. I mean, we can't add it until the regulations go through.
Is it unusual for your advisory committee to sort of give you a deadline or a goal date, or are they particularly invested in?
Well, yeah, it's not unusual, except that I kind of asked the question at the meeting, because when we added the last 3 diseases, there was a sunset date in our statute, because those were added via statute, not via regulation. And we had 1.5 years from the time the bill passed until implementation. But with regulations, there's no telling how long those can take to get through. And so, and our advisory committee is well aware of how long that can sometimes take. And so they wanted to at least express that they feel there's some urgency to try to get this added.
Mm-hmm. Oh, great. Thanks, Julie.
Yeah. And Crystal has our numbers.
Are you ready, Amy?
I am ready.
Okay, so we started screening July 1st of 2018 for MPS 1, Pompe, and XALD. And we have screened about 17,063 babies to date. Then this next part, Amy, I'm going to break down by 2018 and 2019 numbers.
Okay.
Okay, so in 2018 for MPS 1, we had 5 pseudodeficiencies for MPS 1, 1 carrier for MPS 1. In 2018 for Pompe, we had 1 late onset. For XALD, we had 4 that repeated normal, 1 repeat elevation with DNA, but no mutations were found, 1 with XALD, a male, 1 XALD heterozygote, female.
Thank you.
So now, well, I'm going to give you 2019 now.
Okay.
So for 2019, for MPS 1, we have 1 pseudodeficiency, 1 repeated normal. First screen was reported inconclusive, so the repeat was normal. Pompe, we had 1 pseudodeficiency. XALD, we have 1 pending repeat, and we have 1 female pending diagnosis, had 1 variant of uncertain significance.
Thanks, Crystal and Julie. Any questions for Nebraska? So Crystal, can you talk a little bit about your pseudodeficiencies and how you guys are determining that?
From the gene sequencing, our lab does gene sequencing that they perform, and they don't do it right on site, they send it out, but on average, Karen and I were figuring it out, it probably on average is approximately 9.3 days till we get the gene sequencing results back. And then depending what they find, if the lab says if it's pseudo-deficient, we pass that on to the metabolic specialist. We have them put it in writing. If there's something questionable, then they say if they want the confirmatory testing done or not. And they want that all sent to Mayo if we do go to the GAG testing and all that.
Thank you.
Yeah, I just wanted to clarify too that our the sequencing lab is coming in-house.
Yes, thank you.
Oh, great. Does that mean in Nebraska or in Pennsylvania?
In-house at the Pittsburgh lab, yeah.
Gotcha. Okay, thank you. Any questions for Julie or Crystal? It's amazing that regulatory is getting easier. That's awesome. Maybe. Maybe easier. I don't know, Julie. Let's see. Are there any other states that would like to give an update today? Okay, I will turn it over to open discussion. Last time in February, it looks like you guys talked a little bit about what's the process for deciding what disorders are part of the IDIQ task orders. And you guys talked a little bit about that. Is there anything you guys would like to talk about while we have everybody on the line? Everybody must be getting ready for the big APHL meeting in April. Oh, that's great. Yeah.
Amy, this is Jennifer again. I was just asking, wondering if do you know if NICHD is going to be releasing another task order soon, and what it is, what the disorder will be for?
Dr. Watson, do you want to talk about that?
Particular one. Usually it's out in January or February, but I am not certain what their plan is currently, and I don't know if Melissa Parisi is on the call or not. But typically a funding opportunity really can only be announced by the federal agency that's putting it out, and it's relatively secret until then.
And I think the NICHD team is part of an all-day meeting today, so they're probably not on the call. But we can for sure send them that question, Jennifer, just to let them know that it came up on the call.
Yeah, last I heard that they will be releasing something this month, but I didn't know if there was any announcement of a disorder.
Yeah. Yeah, we haven't heard anything official.
Okay, that's good. Thanks.
Yeah. Anything else? Yeah, go ahead.
Yeah, this is Julie. I have a question. Dr. Orsini had mentioned a meeting that's coming up to look at harmonizing cutoffs or screening algorithms. Do you know what that meeting is or when?
No, let's see if Joel will jump in.
And maybe it was just a regional thing. I don't know.
Hello, yeah, this is Joe. Can you hear me?
Yep.
Yeah, the meeting was fun limited, if you will. So I have 10 states involved officially. If there's anybody on here who would like to be a part of it, you can let me know, and I can see what we can do to add you into the process. I tried to pick states that are screening or have lots of data that we can look at, because it's going to be a tricky process. But the meeting is actually going to be later this month, March 25th and 26th. And that's going to be in New York.
And Joe, what disorders is that focusing on?
What is it focusing on?
Yeah, which disorders?
ALD.
Oh, XALD. Okay. Gotcha. Well, we'll put you on the agenda for an update in April, hey?
Okay.
Cool. Anything else you guys would like to talk about today? Okay. Now I'll see if there's any updates from APHL.
Hello, can you guys hear me?
Yeah, we sure can.
Okay, so I just want to remind everyone that New Steps can support travel to the New York, Wisconsin, and Missouri programs for on-site technical assistance regarding SMA, MPS 1, XALD, and Pompeii. So if you are interested in that, please feel free to reach out to me via email to submit a request for on-site technical assistance. Also, if you have any other technical assistance needs for new disorders, please feel free to contact me regarding that as well.
And which states, New York, Wisconsin, and what?
And Missouri.
Missouri, gotcha. For XLD, SMA, Pompeii, and MPS?
Yes.
Okay, gotcha. And what's your contact information, just so I can type it in for folks?
Okay, it's Kashia, K-S-H-E-A, okay, dot, and then Hale, H-A-L-E, at aphl.org.
Great. How many states have taken you up on that in the past, or?
I think it's about 4 to 5 states so far. 4 states.
Gotcha. That's cool.
Yeah, Nebraska, we've got 3 people through that arrangement going to New York to learn about their SMA and their experiences with the other 3 as well, too.
Oh, that's great. How many days do they stay when they go to New York?
It's
I think
1
it's
day.
a day and a half. Yeah, day.
Yeah.
Oh, yeah, it's a day on site.
Gotcha. Cool. Any questions?
And we can do, we can do up to 2 days if necessary.
Gotcha. Great. Any questions for APHL and New Steps? Great places to eat in Chicago. I guess we have more. We'll probably keep an April call, I guess, because we'll all be in Chicago. So
yeah.
So we'll stay in touch via email. Just an update from NBSTRN. Just a reminder that we're looking for volunteers for a new effort where we're thinking through how to better collect the pilot data. I love to type live on these calls, but I'm not the greatest typist, and there might be an easier way for you all to share your counts and your information and track it over time. So if you're interested in that, feel free to send us an email. If you don't want to participate in the process, you can be part of the review process as we kind of come up with some ideas on how to make your lives easier and be able to talk about the numbers as they come in from these new conditions. Just a reminder that this call is the first Thursday of each month, 2 p.m. Eastern. Feel free to email myself or Mike if you have any ideas, questions, or advice for us. NBSTRN is a contract with NICHD, so just an acknowledgement to our funders. And if there's, I'll just give folks a minute or two in case there's anything else that you would like to bring up. You have 92 of your colleagues on the line. Okay, great. Well, we'll see everybody in Chicago. We're really excited, unless you're going to come to the ACMG meeting in Seattle. So we'll see you in Seattle and then Chicago. Take care, everybody. Thank you.
Bye-bye.
Bye.
Bye.